Hello, everybody, and welcome to today's webinar, Venous Leg Ulcers, Painful for the Practitioner and the Patient. My name is Marianne LaFleur, and I'm the Clinical Manager for Monlica, Canada. I'm pleased to introduce our guest speaker today, Dot Weir. Dot is a certified wound and ostomy nurse and a certified wound specialist with over 4 decades of experience. She's the co-chair of the Symposium on Advanced Wound Care, faculty of the Wound Certification Prep course, and secretary of the International Wound Advisory Institute. She currently practices clinically in a wound care center in Michigan. Dot is a national and international consultant and educator. We invite you to submit your questions by typing them into the panel found by clicking on the Q&A icon along the bottom menu. You may submit your questions at any time, and we will collect them and address them during the Q&A portion at the end. A link to the certificate of attendance will be available in the chat at the end of the presentation. Please click to download your copy and complete it with your name. It will also be available in the follow-up thank you email. We also ask you to please complete the survey that will appear in your browser at the end of the presentation. And with that, welcome, Dot.
Thank you, Marianne, and thank you to all of you for joining. And, one of the things that you may have noticed when she was talking about the presentation is that I changed the title, Venous Leg Ulcers. When I first put it, I put painful for the practitioner and the patient, but this is really a very patient-centric problem, so I decided to make it painful for the patient and the practitioner. These are my disclosures. And these are the objectives. We're going to talk about venous leg ulcers. We'll talk about some patient challenges, and then we'll use a few case studies to summarize it all at the end. So I will tell you that as I've been out in outpatient wound care for 23 years. So the walking wounded and especially venous leg ulcers is the number one type of patients that we see in the US anyway, in the outpatient setting. And so these are US demographics, but there's over 500,000 people that get these ulcers every year. And some of them are a lot younger than maybe some of our diagnoses that are older. Because you can see that a lot of them have them before age 30, and then we even have some before age 50 and some before age 30. But recurrence is high. The workdays that you see in the US is about 2 million workdays. There's an article that comes out every year that updates demographics. But if you look at worldwide, there's like 4.6 million workdays lost every year. So it's a very common problem and one that takes people down. There's a lot of challenges, patient resources and acceptance being two of them, and I'm going to talk about those. But they're quite expensive. I tried to refine these, see if there was any updated dollar amounts. But it's about $2,500 a month. In the US, most of these patients are seen in outpatient wound care centers, so that adds to the cost. But about $2.5 billion per year in overall cost. So you can see that the numbers will vary, and I'm not going to spend a lot of time talking about this, but the sooner obviously that we can get them closed and the better education we do to try to keep them from recurring, obviously we're going to drive these costs down. So the challenge is not with the blood flow down the leg, it's the blood flow back up the leg. And so we have, three parts to our venous system. We have our deep veins that carry blood, ultimately shunt the blood back up the body. The superficial veins, which are the ones you can see if somebody has varicose veins. But there's the perforator veins that connect the two that have to go through the fascia and into the muscle. That oftentimes is the problem. So it's a one-way set of valves that the blood, when you take a step, the calf muscle pump engages, and you've actually got a plexus of veins in your feet. So as someone takes a step, it starts to propel that blood back up the leg. The valves continue to move it up because the pulsation and the movement of the leg. And so, if all that's working fine, then the blood goes back up and it's reoxygenated and everything starts over again. So our calf muscle pump is a huge part of this because it compresses those deep veins. And again, that's what helps to propel the blood flow upward. And then when the muscle relaxes, then the veins aren't being compressed. So it's a continuously moving system. And again, requires that the person that is ambulating and that the calf muscle pump is being engaged. And many times that contributes to the problem with the chronic venous insufficiency. But the biggest problem are these valves. And so when you have a normal valve, the blood goes up and then the valve slams shut so it can't flush backwards. But what we have with venous insufficiency is reflux. Those valves are either so dilated that they don't come together. They're hormonally driven. So, like during pregnancy, for example, you know how women get the swollen feet. Well, because of just the weight, not so much the weight of the baby, but it's really hormonally driven. Those valves aren't coming together, hence the edema, which then goes away once the baby is born. So, this valve or dysfunctional valves are really what we're fighting, and how we have to counter that with the use of other kinds of compressive forces. So when we're seeing these patients, we have to get a good history to find out why, especially a younger person, why would somebody even in their 30s have bad veins? Well, they could have had some sort of surgery. They could have had some sort of injury, particularly sports injuries is what we often will see. And then as you get older, other kinds of surgeries, any kind of pelvic surgery, any kind of hip replacement, knee replacement can interfere with the way the blood flow goes back up the leg. If someone's had previous blood clots or DVTs, any kind of infection, cellulitis, trauma, as I've already mentioned. And of course, they may also have coexisting arterial disease, and we're not going to really be able to touch on that much. And so there are other risk factors, and some of those include being a female. There is a higher likelihood with women. And then you can also judge your own potential if you know that your own mother had venous insufficiency or had varicose veins. Someone who's had multiple pregnancies, if there's a family history, as I mentioned. Unfortunately, obesity does come into play with that, but also standing occupation. So those of us that are nurses and are on our feet constantly, then we're at higher risk. And when I was a baby nurse, when I was a brand new nurse, we wore stockings, and we wore compression stockings with some elasticity. And now most people are wearing sneakers and they're wearing socks. So again, we have to watch out for our own legs. But then if someone works as a cashier, who works in a toll booth, or anything that makes you stand still, is putting somebody at higher risk. As I mentioned, leg trauma in the past, sports injuries, and then of course anyone who's had a previous deep vein thrombosis. So when it comes to managing this edema, and that's really what it's all about, the way we can manage edema, the list is pretty short. The choice of management is going to be driven by the source of the edema. Like I think negative pressure wound therapy, for example, is underappreciated as a source of edema, but it does help a lot with peri-wound edema. We're going to be talking about the use of garments and of compression bandaging. That's how we treat most venous insufficiency. Leg elevation will help, but it has to be meaningful. And then one thing I don't have on here are the pumps that people can use. I do want to bring up diuretics, though, because a lot of times we get folks that have been treated in the community with leg swelling, and they've been given lots and lots of diuretics. And unless it's related to cardiovascular issues, the edema that you get with venous insufficiency and lymphedema actually doesn't really do a whole lot for them. In fact, it only could lead to electrolyte imbalances and dehydration. So unless there's a very good reason other than their swelling from their venous problem, they should not really be on long-term diuretics. So what does it look like? So the clinical features of just the disease of chronic venous insufficiency begins at the feet and ankles. You can see a very good picture of that. This was a patient of ours that had the most prominent veins, and you can almost see the valves pulsating. But you can see that vessel is dilated because of the backwash of blood into the superficial venous system. And it only gets worse from there. Varicosities are an unsightly problem too for these folks. So they get worse after they've been standing for a long period of time. Many times they complain of aching, discomfort, which improves when they get their legs up. They often will have this hyperpigmentation that you see in these two bottom pictures. Because the blood is backing up, the capillaries will dilate, the walls become thinner, and so the iron part of the blood, the hemosiderin, will seep out into the tissue and basically tattoo it. Once you've got this dark discoloration, it usually does not get better, just even though you may improve reduce the edema. There are some laser things that can be done to lessen the dark color, but for the most part, this is a change that they're always going to have. They get chronic inflammation and fibrosis of the skin, which will be on the next slide, and some dermatitis that is quite frequent. And a lot of times people have this dermatitis, and so they will go to the hospital, they'll go to the emergency room if their legs are weeping and red. And they if they have a bilateral, they're oftentimes admitted and put onto antibiotics, but it's usually not cellulitis if it's especially if it's bilateral. It's usually going to be chronic venous insufficiency. So the indurated eczematous skin and flame skin is very, very uncomfortable and unsightly, but certainly uncomfortable, and is caused by just that chronic inflammation and fibrosis of the skin. It becomes very dry, very difficult to keep it hydrated. But the management of this is really just exquisite wound care. Part of our education for patients that we're teaching, and education is so critical, I'll say that many times, as we teach these folks, it is really doing very, very exquisitely good wound care, skin care, using good soaps that are nicely pH balanced. Because if we can try to keep the pH of the skin in the more acidic area in that 4 to 6 range that our skin normally is, then we're always going to be able to make the skin a little bit better. So their choice of soap and their choice of moisturizer will be important. Sometimes when we first are seeing them, we have to do more frequent dressing changes and bandage changes so we can be actively treating the skin. And we oftentimes will use topical mid-potency steroids, something like triamcinolone, for example, if it's really inflamed, to be able to quiesce that inflammation. And when we're using these medications, it's really best to put them on twice a day. And we prefer an ointment to a cream. The ointments seem to stay in place longer, and they're very soothing for patients who have itchy, dry skin. And so until we can get that changed, then we probably want to use tubie grip or some sort of tubular bandage that we can, it doesn't give a lot of compression. I'll talk about that again, but at least it gives some compression coupled with leg elevation until we get the skin in better condition, and then we can go ahead and put them into their regular bandaging. So the ulcers themselves are almost always below the knee. Most of them are above the medial malleolus as the initial ulcer. But if you've taken care of a lot of these, you can see them circumferential, and you can see them in all areas of the body. Of the leg. They will have more irregular borders as compared to, say, an arterial ulcer, which are more punched out, symmetrical borders. And for the most part, they're not going to be undermined. Eschar, recurring necrosis, tendon, all these things that you see with deeper wounds are usually not going to be the case with a venous ulcer. It may be, though, a traumatic ulcer or a hematoma, for example, that happened to occur on the leg of someone who has venous insufficiency. Then you might see some deeper changes, but for the most part, you don't see a lot of undermining in necrotic tissue. And so we have to always make sure we're differentiating, that we're not dealing with some other kind of atypical type of wound. Like if it's, there used to be this myth that arterial ulcers hurt and venous ulcers didn't hurt. Venous ulcers hurt. But if they have a pain that seems unusually exquisite or high, or if it doesn't look right, if it's not responding to treatment in a reasonable length of time, that's when we may consider doing a biopsy and look for some other reason. It may be the leg of someone who has venous insufficiency, but it still could be someone who has a basal or squamous cell cancer. So we don't want to miss things like that. Now, there's a term called phlebolymphodema, which is really more the most common type of lymphedema in the Western world. It's a mixture of lymphedema and venous edema. And anyone who does lymphedema will always tell you that all edema has some sort of a lymphatic component to it. But when you have all these fibrotic changes, the venous system and the lymphatic system are very intimate. And so when you have all these fibrotic changes because of chronic venous insufficiency, it is going to impact the lymphatic system. And so we see a lot of people who have symptoms of both diseases. They have the what people call sausage toes, or the toes that are very swollen, just like you see these feet down here. but they have just a different kind of edema. They'll still have the hemosiderin staining, but they could also have these papillomas that you see in that bottom right picture. The treatment's going to pretty much be the same, but it is important to understand that this lymphedema can be a component, and that would also be the person who would benefit probably from some pumps. So the challenges for us in outpatient is that in the areas that I have worked, many times our lymphedema clinics are not set up to do wound care. They are in more of a physical therapy area where they don't have all the dressings and the things and the ways to and the medications that we might need and ways to manage the wound. So I've usually worked in place. There are definitely lymphedema centers that can also take care of the ulcer, but I've worked in areas where we needed to manage the ulcer and the edema until we get the skin intact, and then we can send them on to the lymphedema clinic for management, for long-term management. So we got to make sure we have the right diagnosis, and of course, we need to make sure that we have the perfusion. And so what we see within this is where the painful for the patient comes in, is the drainage at first can be really overwhelming. We see people come in with diapers wrapped around their legs, and ways that they've just tried to manage this at home. If you're in home care, I remember being in home care and people sitting in their chairs with towels and things on the floor, plastic bags, just because they were sitting there weeping until we could get that edema under control. So management has to start with education. We have to have that patient understand why this is happening to their legs, and to be able to tell them this is a life sentence. This is something they're going to have the rest of their lives, but it can be managed, and that very, very rare does anybody lose their leg because of chronic venous insufficiency. But we have to make sure that they have adequate blood flow. So that's why a vascular workup, which I'll talk about, is so critically important. We need to start some sort of compression therapy. This is the gold standard. Leg elevation will help, but leg elevation all by itself is not going to do it. I mean, if that's the only way they can try to manage their edema, they need to be elevated most of the day. But it is hard to totally get a wound to heal just by leg elevation. And then, of course, the management of the wound. We have to address the exudate. We'll be talking about this and use dressings that are meaningful. And then, of course, managing the skin, as we've already talked about. Now, I'm going to come back to that hose with a hole in it, and it'll become more meaningful. I'm going to put you on hold on that one. So what we do is we check the blood flow. It is a fairly easy bedside test to do, but you have to have a Doppler and you have to take the time. We tend to send our patients to a vascular clinic because we have easy access to that, so they can get their our ankle brachial index done and to check their blood flow. But it certainly is something that you can do in your own clinic. And basically, you're taking the blood pressure in the arm and the blood pressure in the leg and at the ankle, and then you use the highest of the two, and it's just dividing the ankle by the brachial. So what you're shooting for is a number one, and it should be even. And if there's any alteration of that, it's usually going to be lower, and that will be on the next slide. So one of the things we have to keep in mind, though, is the person who has diabetes, they have something called medial calcific stenosis, and that just means that their vessels in their feet are going to be calcified. So the blood pressures will be unusually high. So if you have someone who their ABI is like over 1, 1.5 or 1, higher than that, then it's usually, if they're diabetic, then that's not accurate. And so we use the same formula, but we do toe pressures instead so that we can get a more accurate reading. And I'll show you a chart that shows that. So with just looking at ABIs, these are the numbers that are recommended to consider a patient to be at high risk for arterial disease. So, if you're 0.9 to 1, then you're probably okay. But starting at 0.7, then that's mildly abnormal. And at 0.5, we have to really strongly consider whether or not we're going to, first of all, compress that patient. But also, anytime we have any abnormals, we want to refer them on and have someone to have a baseline with them as far as vascular workup to see if down the road they're going to need some kind of vascular intervention. So this is how the toe brachial index is done. That requires very small little cuffs that could go around the toe. And so when you have a lower number in your toe pressures, then you also know that you have arterial disease. But again, the patient who has long-term diabetes, their vessels above the toes are going to be calcified, so it's not going to be as accurate. And so when we look at the toe brachial indices, these are the right numbers for those. I think the bottom line messaging here, though, is that we just need to know the circulation and be very suspicious of anyone who has diabetes, that we go further to look to make sure that we have accurate measurements. So the management of venous insufficiency and lymphedema is compression. And I've had this cartoon here for so long because it says, okay, folks, it's a wrap, because that's pretty much what we do. So edema is definitely the root of all evils, and excuse me, many evils. And so we have known challenges when we have chronic venous insufficiency as well as lymphedema. And then, but what I want to point out is, even though we're talking about venous disease specifically, any kind of edema needs to be addressed. So let's say someone just has dependent edema just from sitting in chairs. If they have an injury on their leg, it's going to take longer to heal. So regardless of the reason for the edema, we must address it. We have patients who have diabetic foot ulcers but have coexisting edema for whatever reason. And as long as it's not, again, a severe arterial problem, if they have edema, then what we need to do is get rid of the edema and do some compression. And here's why. If you look at these two diagrams down at the bottom, the one on the left is normal tissue. The capillaries are close together because perfusion brings the blood down to the foot. Diffusion is how the oxygen gets out into the tissues. So if you have your capillaries that are spread way apart because of edema, the distance that oxygen has to travel is going to be greater. So again, any kind of edema that we can manage will help to bring the vessels closer together and improve the oxygenation. Again, going back to negative pressure wound therapy, that's why it helps, and you can see an improvement in the color and the robustness of the tissue, because the peri-wound edema is being addressed with that. So again, don't just because they don't have hemosiderin staining or they have edema for whatever reason, we want to make sure we're addressing. But it then creates real problems when they have all this drainage. This is where the pain for the patient is probably, if not the highest, at least way up there, along with the disfigurement, the itching, and the changes in their skin. But it soils their clothing, it soils their bed linens. They're constantly wet. They get peri-wound erosion if the management isn't adequate. And so they tend to stay isolated. They tend to stay away from social situations. And again, as I've already mentioned, because of this, they often lose a lot of work days. I mean, they're going to lose time at work just because they have to come in and be treated. But if they can't go to work and I'll address this again, but because of the bandaging or because it's leaking through, that obviously is going to cause them specific issues. So compression is the cornerstone of management. There are many, many, many consensus documents and papers that will really emphasize the fact that we've got to be able to get that edema out. And compression bandaging and compression garments are the way that we do that. And there's so much evidence that just shows the improvement of healing when we can compress versus when we do not compress. So just some basics. It's the application of different kinds of wraps, stockings, garments, pumps to counteract that gravity and help that calf muscle pump to return that blood flow up the leg. So in the absence of arterial insufficiency, sort of the gold standard that people tend to try to strive for is to get compression that's going to equal around 30 to 40 millimeters of mercury. But in my book, even if we can't achieve that, some compression is better than no compression. So we have to assess the patient, the shape of their leg, what their resources are, what the patient's going to be able to tolerate, as we make the decision of what kind of compression to use. And something that cannot be overemphasized is that compression application of any kind of compression is a competency, particularly the compression bandaging. And in the US, we tend to call the disposable things wraps. But in other countries, I was in Australia lecturing at the beginning of the year, and I kept using the word compression wraps, and they thought I was talking about sort of a strap device. And so it is a bandaging technique, but you can cause injury. You can cause injury. So it is something that should be taught and return demonstrated before we just send someone out with a kit and say, go out and, go out and compress. So we want to make sure that we have competencies on file for that. So the choices are many. We have and again, you can see I have multi-layer wraps on here. I probably need to change that. They are multi-layer bandages is really the more appropriate term because these are not reusable. They do make a few bandages that you can wash and reuse, but for the most part, these are bandages that are disposable. It could be 2, 3, or 4 layers, depending on the brand or the type that you use. Ultimately, we want to get the patient into some sort of a garment, and that could be in the form of a stocking. The challenge with stockings, if you do this, is patients getting them on. Many times they can't reach their feet. They often have arthritis or dexterity issues that prevent them from being able to pull on a tight stocking. There are doffers and donners that you can use to frames that you can help patients get them on, and they're not always so easy to use. So we have to really explore with the patient what they're able to do themselves, what help they might have at home to get these on. A favorite of most are these juxtaposed strap garments because number one, it can be adjusted as the edema goes down. And number two, they're a little easier to put on for someone than trying to drag a tight stocking up their leg. And then lastly, there are compression pumps that are available in the United States. They passed a bill, the Lymphedema Act, back in January of 24, that as long as somebody has some component of lymphedema, then they are able to get compression bandaging without having and their insurance and the Medicare here will pay for it. Otherwise, it's always been just a cost that was out of pocket. Or to get compression bandaging and compression garments, you had to have an ulcer. It was just a fluke in our payment system. But now with the Lymphedema Act, if someone has any kind of component of lymphatic injury, which, as I said, most of my lymphedema friends say all edema has a lymphatic component, then they are able to get not only their garments, but also get their pumps. There are some newer, easier to apply. They call it fuzzy whale. There's some elastic knits, and these are very easy to don and to doff, and a very high patient acceptance because of the ease of use and the ability to wear them. And they actually do a very good job. So again, this is just something that we explore with each patient depending on their individual needs. So we really have to work with these folks to get them to accept compression. It's not an easy thing to do. It's not something, it's a change in their whole lifestyle that is impactful. And there's times when these compression garments are unsightly to them. During the summer when you want to be wearing sandals or flip-flops, if you don't have the toes out, then you're not going to be able to wear a pair of flip-flops. And we have to work with people and have them understand that there's going to be times that you're going to not wear this compression. For example, your daughter's getting married and you have a beautiful dress. They're not going to want to wear a compression garment with that dress. So special occasions, we just help them to understand that we need them to wear this for the majority of the time. But there are going to be times, and they have to expect that same wedding dress, that at the end of the night, they're going to have some leg swelling. So education is key. If they can visualize what's happening on their leg, then they're going to be able to understand why we're doing some of the things that we do. But they're always going to need compression. And so generally our wraps or our bandages are short term, with the garments and the strap devices being more long term. Plus, when we're first, and we'll talk about this, but when we're first doing this care, many times there's a lot of exudate and it can be quite messy. And so having a bandaging system that is disposable, we can just throw it away when it's soiled. We don't want to have expensive garments that we're soiling with their wound exudate and their leg leakage, because they're not inexpensive, and they have to be washed carefully. So you oftentimes will use bandaging to get the edema down, get the volume down in the leg, and then we can move them on to their more permanent garments. The ideal bandaging that we use are the ones that are less bulky so that patients can wear their own shoes. And I'll talk about that in a minute. But people need to be able to work. They need to be able to be active, and they need sometimes to have to wear special shoes depending on what their particular job is. And again, more on that in just a minute. And then again, we want to address the skin issues, treat the dermatitis, eliminate the itching, and then we're going to need to try to descale these legs, and I'll talk about that. So as we encourage patient acceptance, and I'll give you a case study of a guy who said he just couldn't be compressed. The ideal is to be able to put a new bandage on when we first start and then bring them back in 2 to 4 days, because when the volume reduces and that leg gets skinnier, the bandaging tends to start to slide down. And so we try to bring them back sooner rather than later, change them a couple of times a week for that first couple of weeks, and then we can many times go to weekly. Now, if they have a work that causes them to perspire, let's say they're landscaping or construction, then their bandaging is going to probably have to be changed more often because it's going to take on an odor. So again, working it out with the patient to make it something that can fit into their lifestyle. And the difficulty is, of course, if they're coming to an outpatient center, in order to get this bandaging put on, that means they have to be away from work. So having some flexible times that they can come in during their lunch hour prior to their job starting. Any way that we can accommodate them, we try to. The other thing about a lot of these bandaging is they have a cohesive bandage as the outer layer, like a Coban type of wrap, and those tend to be sticky. And so if it's sticky, tacky, I guess is a better way to say it, is that their clothing sticks to it. When they're laying in bed at night and they go to turn over, it sticks to the sheets. It's annoying. And so some of the kits come with like a knee-high type of stocking that smooths all that out. Otherwise, we can just use plain old stockinette and cover that cohesive bandaging. It also prevents it from, getting, the other thing that really sticks to this bandaging is pet hair. So covering it with a stockinette can also make that easier to live with. And again, we want to try to enable them to wear normal shoes. We want to try to avoid using like post-op shoes, like cast shoes, because they tend to have a flat foot. And so that makes them clump along. What we want to do is when they have the bandaging on is to utilize that calf muscle pump to walk with a normal stride. And that's so the compression bandage will start that blood flow up, and then the calf muscle pump can assist it. So the other challenge is that not all legs are, one other thing I want to say, I thought I had a slide in here, but maybe I don't. So some shoe options would be to avoid Crocs kind of shoes, because again, I was just corrected on this from a meeting I spoke in last week. I've always had people get Crocs, but an inexpensive pair, but apparently any shoe that you have to hold on with your toes, like flip-flops or sandals, are not going to have you using the calf muscle pump. So if they're going to wear, and I know I'm using a brand name, but the Crocs style of shoe, you should use it with a strap behind so that they can take a normal step and not clump along. So we want them to use that calf muscle pump. But all legs are not created equal, so that's why we have to have more than one kind of bandage to be able to fit the needs of the individual patients. Most legs are not symmetrical like you see with some of these. They have very narrow ankles and lower extremities, and then very large calves by comparison, sort of like an upside down champagne bottle. And the reason is because of the fibrotic changes in the skin, those ankles come in, but the soft soft tissue in the upper part of the calf. It does not fibrose the same. And so you get this very irregular shape. So there's different techniques that can be used, particularly in the bandaging systems that have the cotton layer. You can use that to build up the ankle, because what we want is more of a cylinder shape, and that will always make our compression work better. So again, we need to carry more than one kind of option. And one of the things that I see quite frequently is we will order either a 2-layer or a 3-layer wrap bandage, because we don't want to dictate what brand they're going to use, because everybody has their own formulary. But what folks come in with is, if we've asked for a 2-layer bandage, then they've wrapped them with a bulky bandage, gauze bandage, and then covered that with either an ACE wrap or Coban. That's not going to be adequate compression. 3 layers, they may put a cotton layer. They'll put a Curlex or a bulky bandage layer, and then a Coban. It does not the same. So we need to make sure, if we're going to compress these legs, that we're doing so meaningfully. But we got to work with it sometimes to find something that's comfortable for the patient. And as I said, bringing them back in a few days can help you to reapply a fresh bandage, check to see how their skin is doing underneath that bandage, check to see how the wound is doing, and make sure that they're not slipping down. There are some brands that have like a comfort layer that has a foam, like the Coban 2-layer is an example of this. And if you're using any kind of emollient or ointment on the skin, that foam layer can make it slide. So you may want to cover that with a roll gauze. We want to pad vulnerable areas, so that in a place like the anterior ankle is a common place that people need to be padded. I think I have a slide on that. And building up that ankle if the difference in the size is significant. So here's just some examples of, again, this is just Mepilex foam, showing that the areas that are easily rubbed are the anterior ankle, the Achilles tendon, and that's what good reason to bring them back in a few days, because if there's some slipping, you'll be able to see a red spot that might be vulnerable. So doing it, padding any areas that we think are going to be damaged or that we are finding are getting rubbed is going to be beneficial. Finding solutions to keep them up. Sometimes just using plain old Una's material. Una boots is, you're probably familiar with the zinc paste boots that are used for compression. Not my favorite, because once they dry, the compression pretty much is non-existent. But again, it is a very acceptable way to apply compression. But sometimes we'll just put a little bit of it at the top, and then it makes it stick to the wraps that we're using, and we can leave it on that way. Putting some good moisturizer on. If you have something that's a little tacky, the cotton layer will stick to that, so it keeps it from sliding down. And there are actually roll-ons that they sell for compression stockings, but they're sticky and tacky. And again, when you put that wrap on, then it adheres. This is just an example. These 2 bottom pictures. This is a knee-high hot stocking that comes in one of the kits that can, again, make that Coban layer more slick. And this is just some stockinette to show you what I meant by putting something over it so that the stickiness is not there. Oh, I did have a shoe thing in. So again, this is what we want to avoid. We don't want to use these flat wooden soled post-op shoes. They're okay for a cast or a fracture, but it's going to make them walk flat-footed. And so when you walk flat-footed, you can get up and try it yourself. When you walk flat-footed, you're not using your calf muscle pump. So people are these shoes and the ones up here are gardening shoes, and these are water shoes that really fit nicely. They're flexible. They allow them to use their calf muscle pump. Some folks will just buy extra large sized slippers or sneakers that will accommodate the bandaging. So what we want them to do is to be able to walk normally. And as well, the flat-footed shoes tend to make a little bit higher fall risk, and because their stride is different. So choosing a bandaging system that will allow them to wear some sort of shoe is ideal. Now, the other thing is that we have to make sure we're putting the bandaging the compression where it counts. This is a very specific problem that I like to point out, because the answer works almost every time. This is when you have ulcers in the posterior malleolar area, like back here, when you put a bandage on that, it's going to tent. It's not going to be nice and make intimate contact with that skin under there. Many times these ulcers that are found back here are smaller but very painful. And so what we do is this is just a Meplex border flex on the wound, but we put an extra piece of Meplex foam, or we will layer Meplex foam like you see here, in order to fill that space so that when our compression's on, it pushes down on that area and applies compression, and you'll find that those wounds heal nicely. So this was a patient who had had a recurrent ulcer in this area for like 25 years. And this particular ulcer he had had for 8 months. So we were using collagenase in a bordered foam, and then we were using a tubular bandage at first while we were treating his skin. We were using Tubigrip. But you can see that ulcer is very fibrotic. We needed to get that inflamed skin under control. So this is on the 2 weeks in. The skin was better. It doesn't look like it, but it was. But this is the ulcer that we're dealing with. And so, this is 2 weeks in. It's really not changing much. So at this point, in 2 weeks in, we actually added an extra layer of foam. And you can see that within a week, we now have better granulation tissue. And you can actually see the indentation where that foam is. So it's pushing it in nicely. And again, continued to go on and granulate until he went on to heal. So consider that when you have an area that's indented, that you can add that extra foam so it pushes the compression in, and you'll see amazing changes from that. Now, skincare is essential. We want to make sure that the patients, if they can shower, that's a decision that you make with each and every patient. There are shower boots available at drugstores. They are safer. They tend to have a grip bottom to them, much safer than garbage bags. People will put trash bags over their lower extremity to keep their wraps dry. But they're kind of dangerous. They can be very slippery, so we have to be careful with that. If they're going to use garbage bags, then I would suggest that they put a towel down in their shower so that it doesn't may become a fall risk. Knowing the patient, if you feel comfortable, you could allow them to shower, take off their bandage and shower before they come in. You got to know the where the wound is, the patient's hygiene. We don't want north to south contamination. You want to know what the condition of the water is in any one area. So the decision to shower any kind of wound is going to be based on a lot of things. But if they aren't showering, then we have to cleanse that leg and moisturize before that next bandage is applied at each and every visit. So I'm part of the International Wound Infection Institute. For those of you that will be at NSWAC WCET program next year, we're going to be doing some education on our new wound cleansing document. But we do identify limb hygiene as being critical. Cleansing and drying the affected limb. We have to maintain that skin health. Now, how many of your patients' legs look like this? Well, they don't. So let me go back. So we want to do good cleansing. And again, I can't emphasize enough, if they have compression bandaging on, we must wash that leg with each dressing change. None of us would go around for months and months on end without washing our leg, but we hear stories all the time that they've been in compression and nobody has washed their legs. But that's going to cause a big buildup of scales and skin, and we want to make sure we include the feet and in between the toes as we clean. So I can't see you. I can't see how many of you would raise your hand and say you like to remove scales. But anytime I'm in front of a big audience, lots of people raise their hands. It's so rewarding. But in any event, so I look at scales as having 4 different looks. You've got those that are thick, I call them like tree bark. You have those that are dry and flaky. You have those that are thick and come off almost like a plaque. And then we have some that are more waxy in nature. And so this was a patient who came into our clinic, and his wife said, "Oh, his legs are dirty." Well, his legs aren't dirty. He had this huge buildup of just incrustations, and it's chronic dermatitis. Sometimes there's a little bit of weeping onto the skin because of the edema, and then that solidifies. And so it takes some time, but we ultimately were able to get his legs descaled. Didn't make his legs beautiful, but certainly was an improvement. Now, if you're not familiar with fluorescence imaging, just quickly what it is, it's a device that emits a violet light, and what fluoresces back are porphyrin-producing bacteria. So most of your gram positives and gram negatives will reflect back as red. Pseudomonas reflects back as a bright white CSIM. And so when you look at these scales, the scales will harbor bacteria underneath it. And so this is just showing a team approach where we're trying to get scales off. And this is one of my favorite ways. I just use some of the measuring guides that are made of cardboard, and you can slide it under and get it off. But once you get it off and you can maintain good skin hygiene and limb hygiene, usually they won't come back. But again, this is just what our room might look like after we've done a good descaling. But again, look at the color. You can see that there is bacteria underneath those scales and can be a source of infection. So these are just showing some before and after up here you can see, but these are the plaque kind of scales and they're very easy to remove. But once we get it removed, then let's face it, if you want to treat it with that steroid cream or you want to moisturize the leg, you want to moisturize skin, you don't want to moisturize scales. So we need to try to get rid of them. Now, I will say you can cause injury this way. So I don't want to be cavalier about picking scales off, but we want to easily, gently ease them off because you can cause a break in the skin if you're too aggressive with it. So this is a patient that had these, you can just see this thick skin that's on here. I soaked a Curlex with some hypochlorous acid, and we have Vosh down here in the US, and then wrapped it up with a Curlex, excuse me, a Chuck's pad. And you can see this is just in one sitting. It's not perfect, but it is definitely a start. And again, it doesn't have to happen in one sitting. You can do it over time. Then we want to address the exudate issues because that's going to be the piece that's leaking out onto the patient's skin, can not only cause, unsightly, odorous problems for the patient, but also can cause peri-wound exudate erosion. So we know that the skin issues are maceration, erosion, which can become painful. They can get secondarily infected, but the quality of life piece is why we need to get the exudate under control because of the odor. And it does create reasons for frequent dressing changes, which also can increase the cost. So the bottom right picture, you can see it looks like that material, that fibrous dressing is doing a reasonably good job. But when you take it, that one's just that dripping leg that I think I showed you before. But when you take off that dressing, if you're still seeing maceration, it may be absorbing it, but it's not moving it into another dressing. So we want to maybe look at changing the type of dressing that we're using. So I'm going to finish with a couple of cases. This is a person with a venous leg ulcer, and you can appreciate significant edema. You can see the past medical history there. What did have inflammatory bowel disease, but you can see too that he has quite a bit of edema. And so if you recall, I had that picture of that hose in an earlier slide. And if you've ever had a hose that had a garden hose that had a hole in it, the water comes out. And so that's kind of the analogy I use with these venous ulcers as we compress them, is that the fluid's going to follow the path of least resistance. And so as we got him under control, you can see that he has significant reduction just in the first week with his edema. And but this is where that exudate went. So this is Meplex Border Flex, and you can see that it is completely filled with fluid. But the beauty of that dressing is that when you peel it back, you see there's not pooling underneath it. And so we continued with that same plan of care. It was very easy. A couple of weeks in, 3 weeks in, he was pretty much epithelialized. This is a fellow, again, the kind of patient that I told you about that works construction. He had a long history of venous leg ulcers because traumatic injury. He developed this wound on his leg. This one had undermining because it wasn't just a venous ulcer. He was otherwise pretty healthy, had great perfusion. So we initially used a gelling fiber dressing and covered it with a Meplex Border Flex, actually, and then used a 4-layer wrap. But what happened is when he came back to the clinic, then we had pooling of the exudate. So we switched him from the original gelling fiber that we were using and started using ExuFiber AG on that. And ExuFiber, if you're familiar with it, is a polyvinyl alcohol fiber. So it really does a better job of moving exudate out of the wound and into the Meplex Border Flex. So again, you can see he did great, started to granulate, continued to use the compression, and eventually we were able to take the gelling fiber off and then switch him over to Meplex Border Flex alone, and he went on to close. So this was a fellow who was referred to us during the pandemic, who was a robust, strong guy, corrections officer, retired. He had venous insufficiency, but unfortunately, the nurse-run clinic that he was going to close to us had to close during the pandemic. She called us and said she was sending him our way, but warned us that he said he cannot be compressed. He was taking care of it himself. He was going through 100 ABD pads a month. He was putting zinc barrier all over. He was buying his own Una's boots, but he was only wrapping himself to hold the dressing on. And he was changing it every single day. So it was not effective. And so you can see the erosion. His wounds are actually right here. But the exudate was what was causing all this erosion on the back because it was just gravity was taking it around to the back of his leg. And so we counseled him and said, you've got to be compressed. He had significant edema in his legs. And we worked it out with him. Come back tomorrow if you want. Come back. If you hate it, cut it off, but come back in and let us work with you in order to find the right kind of dressing. And so we were using Mepilex border. We were using, Exufiber AG and covering it with a big super absorbent product, and one little area stuck. And he said, no, 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 don't use that. So we changed only over to a polyurethane foam, which and a two-layer compression system. He had looked better, but then it all got worse again. So we went back to the Exufiber AG, used a super absorbent, used the two-layer dressing, changed him twice a week. And in 3 weeks' time, all of that was healed. We just needed to get the exudate off of his skin. But you can see the dramatic reduction. We made a believer out of him. And this fellow, this was from Saratoga Springs, but when he was a big outdoorsman, a hunter. He did snowmobiling, he did off-road three-wheeling or whatever. And so whenever he would have a boo-boo on his skin, he would immediately come in so we could bandage him. He was good about wearing compression socks. And so we made a believer out of him. So this is the last one that I'll share with you. This is the complex venous ulcer patient that we're currently taking care of. He's not homebound, so he comes into our clinic here in Holland twice a week. And so he doesn't like change. His wounds are very painful. And so we have hit on different kinds of dressings that we've tried because he had very strong feelings about what he was going to use. So we finally found one. And that one was called Mepilex Up. I don't know if you've had a chance to try Mepilex Up, but it's very different. It's a dimpled foam dressing that Mundlicka makes. And we were using foam dressings and alginus on him, and you can see at day 0, it just wasn't doing. He was pooling, nothing was cleaning up. And so we tried the Mepilex Up on just his foot wound at first. And then once we saw that it was doing well on that, then we moved it to all of his wounds. But I just want you to see two dressing changes at day 0 where we started, at day 3, and then a week later, you can see the significant improvement in those ulcers. This was his foot wound that we trialed it on at first, and he found it so comfortable. Plus, he was encouraged by how good it looked. So he allowed it to continue. Now, this is more than a month ago, so he's pretty much close to being closed right now, I believe. But anyway, this is just his right lateral leg. Again, the improvement that you see the texturizing there. Mundlicka makes no claims about what that does, but I see significant epithelialization occur when we use it. But what the dimples do is tend to move the exudate out even against gravity. So it's a really nice dressing to use under compression. So that's where he stood at that time. This is a wet wound, I'll call this. It was a week. This was a patient who had been using the peel in place by Solventum. It's a VAC dressing, which had done very, very well, but his machine, something happened anyway. He had to take it off, and he pooled and had some erosion of his skin. And so we put the Mepilex Up on, and you can see that's just in 1 week's time, just by moving that exudate up and off of his skin. So we want to make sure that we're rethinking non-compliance. We can't be my way or the highway. I have the Walt Disney World picture there because when I worked in Florida, we were the closest clinic Sonic to Walt Disney World. And so we had to think about their costume that they were going to wear and find a way to get the compression that would work with their lifestyle. And then once the patients are healed, I'm going to move through the rest of these because I'm running out of time. I want time for questions. We need to make sure we've got the plan in place for their garments that they're going to wear. And again, the plan in place that they're going to hopefully do better, make better lifestyle choices, but also to be come back in if indeed they are have any break in the skin. And we want to be very clear with instructions. This was a fellow who was put into compression stockings someplace, and they said, you've got to wear these for life. This is just something you're going to always have to wear. So he didn't know that he had to take them off every day. So he had had the same pair on for 3 months, and his son went to visit him and saw that these things were bloody on the front. And when he brought him in, he had them on for 3 months, and you can see they had eroded right into the anterior part of his ankle. So we started compression. Again, you can see his legs are thinner, and we were able to get those healed. And then, of course, so that we just have to be very clear with the instruction to the patient. So teamwork definitely makes the dream work. We have to make the patient a big part of the decision making in this, having them understand what's going on and what they need to do on their part, and what compression is, just what their disease process is, can definitely make them a more willing player as we set up that plan of care. So I thank you for your attention. I'm sorry I had to race through the end. They asked me about my timing on this, and I'm terrible at timing these things. But anyway, I hope you have picked up some pointers, but we definitely want to go to questions. So, Marianne.
Oh, my video is not, there we go. Thank you so much, Dot. That was so informative with so many great pictures. And we have a ton of questions here, but we'll try to get to a couple of them before our time is up. Can you comment on wound care with various agents such as Vosh, etc., for cleaning and cleansing wounds? Any agent you would apply to help prevent cellulitis, and any particular dressing to absorb exudate?
So you're definitely speaking my language there. Hypochlorous acid is which Vosh is the brand name that most people know, is definitely the leader. And the whole wound cleansing document, if you go to internationalwoundinfectioninstitute.com or just Google International Wound Infection Institute, we have a brand new cleansing document, and when we looked at cleansers, hypochlorous acid was definitely the safest, more effective. And antiseptics are definitely a better choice than just plain saline. So that is, part and parcel to preventing infection, because you're using something that's going to effectively kill bacteria, is pH balance, and is also going to not cause harm to healthy cells. And so, that's always been my go-to when we do on a lot of venous ulcers, we'll do a soak with it first. And then you have to have a bandage that matters. And so for highly exudating wounds, and that's why I like doing things with Mundlika, the combination of the exufiber, we tend to use the AG just to have some bacterial control. They do have a plain exufiber that doesn't have silver. But that coupled with Mepilex Border Flex, I liken it to a baseball team. You have to have a good pitcher, but you have to have a good catcher. Exufiber does such a better job because it's a polyvinyl alcohol fiber of moving exudate up and out of the wound. And then the Border Flex, you could see that one that was all yellow, that was Border Flex, will absorb the heck out of it. So it's all these combinations of things. And once you get some of the pH under control and the exudate down, you're going to find less volume. So the needs for dressing changes will fall less.
Awesome, thank you. And this one's near and dear, I think, to everybody in home care's heart when they hear this question. What would you suggest for the heavier client who sleeps in a recliner and has venous ulcers on the back of their legs? They currently have wraps that they remove at night.
Oh, that is a challenge. All I can think to do is to, just like you would offload their bony prominences in that same chair, although there's no bones in the back of the legs, but first of all, hopefully the exudates managed, because that's where the pooling will happen. But I would say if I would think it would be uncomfortable, but they can have their legs up on pillows in that recliner, so that, the ideal is that you have the legs 18 inches above the heart. That's not always simple, but getting their legs up as high as possible. And maybe if they take off a bandage or a tighter compression wrap, garment of some kind at night, if they're able to, like something like Tubi Grip, if you have that in Canada,
Yeah.
adds about 8 millimeters of compression on a single layer. So it gives you a little bit of compression so that maybe that could be the nighttime wear in order to not have his legs swell in between. Hope that helps.
I think that's a great answer. I think we're probably at the end. We're at 12:59 right now. There are so many questions in here, so maybe we'll be able to address those at a later time if Wounds Canada sends them out. I just want to thank you so much, Dot, for your engaging talk, and we hope everybody enjoyed the webinar, Venous Leg Ulcers, Painful for we switched to the patient and the practitioner. Don't
And
forget to
they
click
will,
on the link.
let me just say, I went too long, and so I will personally answer the questions just but if they will give permission for me for the email to be sent back out to them.
That's awesome. Thank you so much. And everybody in the audience, don't forget to click on the chat box to download your certificate of attendance and complete it with your name. A follow-up email will be sent next week with an opportunity to view the on-demand presentation and again with the link to the certificate if you were unable to download it today. If you have any other questions, please contact either us at Monlika at info.ca@monlika.com or Wounds Canada at info@woundscanada.ca. Once you leave today's presentation, for this webinar will appear in your browser, and we would appreciate if you would complete it and provide your valuable feedback. On behalf of Weir, Monlika, and Wounds Canada, thank you so much for joining us today, and enjoy the rest of your day, everybody.
Bye.
Bye. Thank you.